In this audio lecture, we're going to be talking about fluid deficits. Okay, so in the previous lecture, we talked about fluid excess, and if you haven't listened to that lecture first, I would go back and listen to the fluid excess lecture before you listen to this lecture, because I provide a nice introduction into fluid balance in the body. So what is fluid deficit? This is going to be a loss of fluid from the body. Okay. Commonly, this occurs as dehydration, and dehydration specifically refers to water loss without a proportional loss in solutes. Um, so, oftentimes, this occurs just as water loss and not really a change in electrolytes. And so this leads to a decrease in fluid and then an increased concentration in blood solutes. So in our body, when we sweat, proportionally we lose more water than we do salts because we reabsorb some of those salts back into our body, like we learned in cystic fibrosis. Now, as those solutes accumulate in the blood, now osmolarity is increasing, and a dehydration state is resulting. Okay. And so in the blood, so in the intravascular impact, so it can impact the compartments differently, right? So intravascularly, this can result in a condition called hypovolemia. Hypovolemia can be caused by dehydration, hemorrhage, or any other real number of disorders. Okay, but it's going to be a fluid loss without accompanying electrolyte loss. Okay? That is not always the case, but it oftentimes is. And the next condition, we could see that they are hypotensive, right? So if the blood volume goes down, blood pressure goes down as well. So blood pressure is directly correlated, directly affected by the blood volume, and so we see individuals with this fluid deficit oftentimes suffer from a hypotensive state. Okay. And so this can impact the intracellular component because now since our blood is becoming more and more concentrated, we're going to be increasing the osmolarity of our blood while decreasing the osmolarity, or not changing the osmolarity of our cell. If the osmolarity of our blood goes up to, let's say, 310, and then the osmolarity of our cell is still 280, we're going to get water moving from our cell, okay, into the blood. And so this can result in cell shrinkage. And so our blood in this case would be a hypertonic solution. So what can cause this fluid deficit? So first and foremost, inadequate fluid intake. So if you don't have fluid coming into your body and then you get fluid loss, even if it's just normal loss, we can see this fluid deficit occur. Some additional fluid loss characteristics can be gastrointestinal losses like vomiting or diarrhea. Okay. Excessive diaphoresis, which is excessive sweating. And so if we look up here, we can see this person is sweating quite profusely. They're losing a lot of water from their body at that point. Unless the water is replaced through intake, it can't really be made up from metabolic processes. Okay. A prolonged hyperventilation, so your lungs, as you expel air, specifically out of your mouth, you are losing a lot of water in that process. In your nose, we have water retention mechanisms, but it doesn't save a ton of it. So this prolonged hyperventilation can result in this excessive fluid loss and fluid deficit state. Additionally, we could see that hemorrhage can cause this. So this is not enough blood here to cause this fluid deficit. Rather, this fluid deficit hemorrhage would be probably a much more severe wound, something that is resulting in a lot of blood loss. Okay. Next up, we have nephrotic syndrome. We already discussed this as to why that is the case, and so we see nephrotic syndrome really manifested itself as one of the key signs that it was nephrotic syndrome was the decrease in blood albumin. Okay, so this is would be due to the proteinuria, and so you have a decreased colloid osmotic pressure. Specifically, so it acts the same in the kidneys too, and so we see an increased glomerular filtration because of that decrease in colloid osmotic pressure, and that we can't reabsorb as much water as we should. Okay. Then we could have diabetes mellitus, type 1 or type 2. Doesn't really matter. If you have an increased amount of glucose in the urine, in the filtrate, then it's going to act to pull some of that water out. So that is the definition of diabetes mellitus, is having urine glucose in the urine. So that glucose has an osmotic draw, and so meaning we have a strong force opposing glucose or water reabsorption. We have some other causes, and diabetes insipidus is another form of diabetes, and diabetes insipidus is really we're not producing enough ADH now. So this is Zoidberg for anybody who doesn't know, and so he says this insipid urine, no sugar added. And so with a reduced amount of ADH, we are urinating more. That is leading to this fluid deficit. Okay. Burns, as we've already discussed, are a primary route of water loss, and so they need to be covered fairly quickly. Open wounds also offer the same opportunity for fluid loss as burns, and then ascites. Ascites is fluid accumulation in the abdominal cavity. Once it gets in this abdominal cavity, it's not really useful anymore. We can't reabsorb it too effectively. So any kind of effusion, like pleural effusion or pericardial effusion, can reduce the amount that is in circulation. If you consume a lot of caffeine or diuretics, like Lasix or alcohol or caffeine in my case, we are going to be producing more urine in that case. Okay. And then we could have osmotic diuresis, and osmotic diuresis is going to be really this draw for the urine formation, this osmotic pressure for urine formation. So how is fluid deficit going to manifest itself? Well, it has a number of manifestations, and we're just going to kind of go through them. I'm going to explain them like I generally do. So the first manifestation is obviously a thirst. So this is considered a dipsogenic response. And so we see this young lady up here. She wants to drink some water because she's thirsty. That is a manifestation, right? So the osmoreceptors in your hypothalamus are triggering this dipsogenic response. You're likely releasing antidiuretic hormone, and further increasing it, and angiotensin II can also cause the dipsogenic response. Now we see that we could have an altered state of consciousness, meaning the osmotic conditions are now altering neural function. Hypotension, because now we're stealing this fluid from our circulation, and as the blood volume goes down, so does blood pressure. Tachycardia, because we are in this hypotensive state, we need to circulate increased cardiac output. Okay. A weak and thready pulse. So weak and thready pulse, when I looked up thready, the general definition that I was getting from the internet was weak, but it also included rapid. So a weak and rapid pulse would kind of be described here by hypotensive tachycardia. And then the opposite of fluid excess is that had a jugular vein distension. We're going to see flat jugular veins here, and so we're not going to see these well-rounded jugular veins present. Okay. We could see decreased skin turgor, so now you could do the skin pinch test, right? And so if the skin ends up standing up after you pinched it, that means that you're probably suffering from some level of fluid deficit. So when you take your pets to the vet, they oftentimes do that pinch test to look at state of hydration, meaning how fast the skin goes back to its original shape. We could get dry mucous membranes. So here's a tongue here, and this person has dry mouth. And so this dry mouth is the result of dehydration, right? That is really one of the first manifestations that you're going to see. we're going to see that we have oliguria, so the decreased urine production, weight loss because now we have lost fluid, and then sunken fontanelles in infants. So how are you going to diagnose this? You're going to collect a history and physical examination of the patient looking for any of the manifestations that we just saw. You're going to monitor daily fluid intake and output and the body weight as well, very similar to fluid excess. And then for blood chemistry, then you're going to run lab tests looking at blood chemistry, urinalysis, and the complete blood count. So the blood chemistry, you're going to expect there to be an elevation in blood osmolarity. Okay. Urinalysis, you're probably going to be expecting an increased urinality, osmolality in the urine as well, and maybe even presence of sedimentation. Okay. In the complete blood count, we're going to be predicting a polycythemic response because now red blood cells are going to be elevated, not because we're actually seeing polycythemia due to elevated erythropoietin secretion, but now we're seeing an increased concentration of erythrocytes present in the blood because plasma volume is decreased. So how are we going to treat this? First, we need to identify and manage the underlying cause. So we need to look at the initial problem. So whether it is a neurological in origin or it is excessive sweating, we really want to treat this disorder to replace the body fluids. Okay, if it's a reduction in fluid intake, then we want to accommodate for that too. Okay, so the first treatment would be to deliver oral fluids. Okay. The second disorder would be delivering intravenous fluids, and so here we could have isotonic or hypotonic for extreme fluid deficit. So, if we are in extreme fluid deficit, what we have done is we have really sucked a lot of the water from our cells, and so if we look at this and we're experiencing cell dehydration now, meaning we've pulled some of that water out of our cells because now the osmolarity really favored the movement of water in that direction. We want to replace that fluid by delivering a hypotonic solution because now our body fluids are more concentrated in the cells. So that goes back to my 310 versus 310 versus 280 example of osmolarity. So that is the end of my fluid deficit lecture. I hope you enjoyed it. Stay tuned for the acid-base portion of this chapter.